Welcome, everyone. Thank you for being here at the LACNETS meeting for May. We are here in lovely Redondo Beach. This is the cancer support community, and we thank them tremendously for providing this amazing room for us and hosting us this month. I'm Giovanna Imbesi, and our team with LACNETS is here with Lindsay Judavine, our Director of Communications and off-camera, and Lisa Yen, our Program Director. So our full LACNETS team of 3 is here. And we also have our wonderful AV team, Rich Tamayo, who, if you've ever gone to our incredible library of videos, is the one who's always behind the scenes, making sure you can see this. So today we're gathered. We have a very special guest who I'll introduce in just a moment, but a few announcements first. We have every year we do a big conference. It's a full day conference, and this year we've been rotating between our 3 institutions here: Cedars-Sinai, UCLA, and City of Hope. This year it's Cedars-Sinai turn, and so we will be back there again. It's on June 8th, which is a Saturday. It'll be a full day, and if you haven't registered already, we have flyers up front that have the registration link on them, and Lindsay can also help you with that. So why would you want to come to this? It's a full, long day. You might have to drive. What are good reasons? Have people gone to an annual conference before? What were some of the reasons it was all worthwhile? Or was it worthwhile? Yeah, that is so true. I mean, especially for our disease with neuroendocrine cancer, there's always something new. Research, clinical trials. We've been really fortunate, actually, the last few years of having a few things approved. So that's a good point. Yes? I swear she's not a plant, but yes, networking with other patients. I mean, you know how it is to talk to your friends about this, and you're trying to explain gallium and, radiation, and it's hard because there's so much vocabulary. We call it learning to speak net. And so when you can talk to someone who knows what the heck you're talking about, and you can just cut to the chase and talk about, well, how are you feeling? How is that treatment for you? It makes all the difference in the world. And I mean, I've experienced this recently, having a liver surgery, and I just, even after being in this 14 years, I wanted to talk to somebody else who had a liver resection. So it just helps to, be able to be with our tribe here, as we'll call it. And we have...
Tribe, it's a crusade,
it's a crusade.
Right? You guys are warriors in the crusade.
And also for people who are newly diagnosed, the conference is wonderful because we try to bridge, information that if you're brand new, and then information if you've been experienced and diagnosed a while ago and considering new treatments and coming to learn. So we go through everything from oncology to pathology and all the radiation treatments available, liver-directed surgery, and PRRT, of course. We talk about symptoms. We talk about carcinoid syndrome and what it's like to live with that and what's available now if that's something that you're affected by. We're going to have lunchtime discussion groups, as we did last year, which worked out really well. So on the lunchtime break, you can actually sit with some of the presenters and have a smaller discussion with them and have some of your questions answered. And one speaker who we're going to have is this woman, Lori Todd. Lori is known as the insurance warrior. Thank you, Dr. Liu. She's written 2 books, and she specializes in helping people with having insurance issues, which so many of us have had. It's like, sorry, denied, or you have to fight and you're trying to get to see a specialist, like Dr. Liu, and your insurance doesn't want you to do that. So Lori actually had her own case, which is what started her on this path, and then she started doing this for hundreds of other people and wrote 2 books. So we're flying her down from Seattle, and she'll be with us as well for June 8th. Also, we will have a live Q&A after Dr. Liu's presentation. Feel free to ask questions online and here. And the LACNETS video library is on our website. There are over 100 videos. So if there's something you have an interest in and you'd like to slowly go through it, pause, rewind, that's a great resource for some topics. So we have a private email group, which we started a few months ago. And this is just for people within LACNETS in the Southern California region. So we wanted to have a place. We could have done it as a closed Facebook group. Many of you are on those. But some people are not on Facebook. So we wanted to have a way for people to communicate with each other. And some of the questions that have come up is, like, which one is better, sandostatin or lanreotide? And that answer really comes from all of you and your experience. So when you share your experience with someone who's trying to make that decision, it really helps them out. We've been asked, who's the best doctor? Where do I go? So our private email group is a great place to ask that kind of question, and people will chime in with their experience, and, oh, well, maybe I went to Denver for surgery. So I encourage you to sign up for that. It's a really robust group. And lastly, couple of meetings. We're going to take July off and regroup after the June conference. And then in August, we're going to be having more of a summer get-together potluck, which will be in the South Bay as well. So stay tuned to the LACNETS newsletter to get information on that. And so without further ado, our very, very special esteemed guest, still with the most highly viewed video from 3 years ago, Dr. Eric Liu from Denver.
All right. Well, thanks for coming. The title Giovanna and I came up with was Decision Making for NETs. And I think she kind of had the idea that, well, maybe we'll decide like what therapy and stuff like that. I'll do that for you. I'll discuss all the things. We'll do that. But I've decided what I'm going to do is I'm going to divide this into 2 halves. Okay. So if you came 3 years ago when we were sitting at that community center, I basically sat here and just kind of talked about like how to approach your disease. So it's kind of similar what I like to do, because it's not fair for you guys to figure out what treatment you're going to have and stuff like that. I mean, it's good for you to understand, but that's what the healthcare professional is supposed to do for you, right? But there are a lot of questions and decisions that you guys make as you go along. And so having done this now, I think I've seen almost every kind of variation of person come through the door, although every person who comes in is different from the person who left. But I have picked up a few things, which is really important. Now, there are a couple seats if you guys want to come in. There are a couple seats in here if you want to come in, yeah. It's so far away. So, but we'll talk about it. And, I'm easy, I'm open. So by all means, if you have any questions, don't hesitate to ask. But I like to think that decision making is more than just about what treatment am I going to have. It's also about how am I going to approach this right here. Yeah, how are you going to approach this whole thing? And that's kind of hopefully what we can talk about today. I will go over the surgery and the PRRT. We can figure all that kind of stuff too. But for the first half, let's just think kind of more generically. So just so you know, I do work with a lot of the companies too. So Lexicon's out there. You should stop by and look at their booth. But I work with them so I can educate. And so we can get out all around the country and teach all about neuroendocrine. So that's something that my wife likes for me to not be around. So the first thing you want to know, like, what are the questions, right? So here you are. Tell me if this sounds familiar. You go to the emergency room. You have some weird, vague abdominal pain. And the emergency room doctor comes out and tells you, oh, you have all these lesions in your liver and you have a blockage. Anyone have that? Heard that before? Okay. Anyone gone and like say, oh, yeah, you have these symptoms. Don't worry, it's just stress. Does that sound familiar? Or you'll walk in and people will say, oh my gosh, you have terrible cancer. You have 3 months to live. Right, who's heard that before, right? Right. Yeah, so those are very, very, very common stories. So now you're like, what do I do? Right? You've been hit with this massive, terrible, awful news, right? And then you're sitting there, and it's hard to even grasp what it is. You have no information, right? You have no idea who the person who just told you that news has any idea what's going on. And you're now all of a sudden facing your mortality, like very, very, like right up front in your face, right? So, now that I've done this for a while now, the first thing to do is always just to kind of take a step back, right? And just take a deep breath and say, wait a second, what just happened? And if you're diagnosed with neuroendocrine, the good thing about it is you do have a little bit of a breath to take, right? And so you can kind of figure things out, and we'll go through the questions. If you have, really bad lung cancer, that's bad. If you have really bad pancreas cancer, that is bad. If you have really bad brain cancer, I mean, that's awful. You don't have a whole lot of time to figure things out. But for neuroendocrine, it's a little bit different, right? So let's just go through some of the questions. So the first always question is, how much do I understand my disease? Like, what just happened, right? Do I have everything to make an understanding and educated decisions about this, right? And then the next question you have to ask yourself is, well, how much do I really want to know about my disease, right? There are people, and you guys are probably self-selected, but there are people who want to know everything about the disease, right? They want to know like all the reports and the values and all those kinds of things. Who's the best doctor to go to? And then there are people who are just like, look, I don't want to know. Just tell me like where to show up for my shot and what to do, right? There are people like that, right? So you have to ask yourself who you are. Then another really important question is, okay, well, I have this kind of weird, unusual disease, right? You go on Dr. Google, and Dr. Google tells you all these like crazy things, and you can never quite figure it out. And then you have to figure out how much does it really match what you hear from your physicians and your nurses and your medical team that you work with, right? So if you ask a question, and the doctor keeps telling you the wrong answer like 3 or 4 times, you're like, maybe this doctor isn't as well versed in my particular cancer as I would like him or her to be, right? So you think about that. And if I just may say, this is a problem, especially in our field, right? The trust with our local people. It's not that they're not wonderful, smart physicians and nurses and stuff like that. It's just they just don't have experience with it, right? So then the question becomes, well, how much do I want to dictate my own care, right? And so all of a sudden, when the patient realizes maybe I know more about the disease than my physician does, right? You walk in the door and you say, I want PRRT. And the patient's like, what does PRRT stand for? Right? Then you have to start thinking about how you're going to control your own care. And then, of course, do I need more support? Now, of course, I'm preaching to the choir, right? So this is not exactly the right audience. But for people who are out there, you have to ask yourself, am I okay handling this by myself, or do I need a buddy to talk to talk about the symptoms, to talk about the treatments, to figure out these things? Do I need more information? The answer should always be yes, right? It should always be yes. But sometimes people don't even realize there's more information to be had. People sometimes don't realize that there are different kind of therapies and treatments that can be even explored. They hear, oh, here's your shot, this is what you're going to have, this is what happens, and that's it. I think you've all probably heard some variation of that kind of story. And then an important one, which is actually the last one that I did 3 years ago here at the group, was would I feel better seeing a NET specialist, right? And NET specialist is a very, very, very vague term, okay? It is a very vague term. There are lots and lots of doctors who claim to be NET specialists, and not that they're not, great oncologists or whatever, but then there are people who do more NETs, right? And so they understand the disease a little bit more familiar, go to the meetings, think about it a little bit more. And then there are a handful of us who just do it all the time, right? So I've actually seen quite a few people in this room. And so when you come to my clinic, right, everyone in that room has the same, has neuroendocrine, right? So, it's very frequent for me to see in a day what a community physician would see in a career or in a year or whatever, So, but you have to decide whether this is something that you want to do. And we'll address all these things a little bit. And then the other thing to think about too is sometimes, am I okay firing the doctor that I'm currently with, right? Not that, you want to, but sometimes, some physicians think, well, I know everything, right? And believe me, my wife tells me all the time, I don't know everything, right? So I'm reassured of that. But every day. But sometimes some physicians are like, look, I'm the boss, I know what's going on, this is how it is. And sometimes they don't play well in the sandbox, right? And so you have to think, well, is that what's best for me, or should we gather a team who can all work together and kind of figure things out? So that's something you have to think about. Hopefully that's not the case, but think about it, right? And then another question is, are you communicating well with your team, right? Because neuroendocrine is it's a very kind of unusual, odd disease, right? So people have weird symptoms. There are treatments for it. We should figure that stuff out. And so, are we really having that good conversation? And I'm not awesome at that because I have to take care of people from quite a distance, so it's not so simple. But at least with your local team, is that possible? And then you ask yourself, okay, well, I just sat down there. Doctor just explained it to me. Am I okay with the plan I just received? Maybe it's okay. Maybe it's not, right? Are you okay with doing nothing? Because I know there are some doctors who say, oh, that's neuroendocrine. That's not really cancer, right? You've heard that before, right? And then they'll say, just do nothing. You'll be fine. You're cured. You're cured. Anyone told you that before? Oh, you're cured of your cancer, right? And then there's some doctors who say, oh, wow, you need surgery tomorrow, right? And you're like, whoa. I got to make sure my dog gets walked, right? So things like that. So is that too aggressive? Or are they going to put you on chemo in maybe an inappropriate situation? I don't know, but you have to think about that. Do I understand all the options, actually? So putting out all the cards on the table and thinking about what the options are and what the tools in the toolbox are is critically important, because all of you have various different ways of reacting to different treatments or how you want to do it, even psychologically. We'll talk about that in a second. And really, does this make sense to me? I mean, again, I will reassure you, my mother thinks I'm the smartest person in the world, and my wife thinks I'm the dumbest person in the world. So if this doesn't make sense to you, then maybe think about it again, okay? And then, am I comfortable with my care plan? I'm not like today. I mean like in a year, in like 3 years, in 5 years, in 25 years, hopefully, if all goes well, right? So are you comfortable with that? And then finally, like the really annoying things, like, this is not annoying. How am I going to balance my disease with living my life, right? This is super important. I know I've had this conversation with multiple people in this room, right? Because some people are like, oh, they get obsessed with the disease, right? And I'm like, look, that's my job, right? I should help you take care of that, and your job is to live your life, right? And for those of you who have come to see me, I've said this before, you can get hit by a bus, right? Or in Los Angeles, you can get in traffic and just get rolled over, I don't know. So, these bad things. So you have to judge that, right? And we'll talk a little bit more about that. And then, as Giovanna kind of presented, well, okay, now what? How am I going to decide to deal with all these insurance headaches? Because Lord knows there are a lot of insurance headaches, and I live that every single day. So these are very, very, very challenging questions. And I'm sure you have more questions. But these are kind of the decisions that we have to make as far as, if I'm part of your team, these things I have to think about for you, you've got to think about and tell me, and we communicate, and that's really what's critically important, okay? So let me just make a couple of disclaimers first, okay? The first important thing is I cannot tell you what to do. I cannot tell you what to do. First of all, it's not who I am, right? And more importantly, it's a team effort. Okay, so I need to know how you feel about it so that I can guide you through the process, right? And then most importantly, there is no right answer. That's the problem with neuroendocrine. Neuroendocrine is like a web of treatments with a whole bunch of tools in the toolbox. And maybe this will work, or maybe that will work, or maybe this won't work, and maybe this is good for you in this situation. So it's not so simple, right? And that's the problem. There's a weird bias in oncology. Neuroendocrine is kind of seen as an easy cancer because it doesn't kill you right away. And in that sense, that's great, right? That's great. However, it's actually super complicated from the decision-making process because the patient does so long, the standards are higher, right? So if you do nothing, it's true. They can probably punker along, do great for a good long time. Yeah, punker along. That's right. But usually what happens, they do great, and then all of a sudden they collapse and they fall off, and that last year of their life is pretty miserable. And so I always say to people, it's easier to keep you up here than to start pulling you up from down here. Does that make sense? So that's why I think it's so important to have a good team surrounded around you. And because we have a whole bunch of different treatments, that means that we have to decide, well, what's the best treatment for you at this time? Is it the right time? Is it the right team? All those kinds of things, right? So it's actually a much more complicated cancer than the other ones. And I'll show you what I mean. So these are kind of the other usual cancers, right? And there's a very hot topic in oncology, which is basically pathways. This is what you do. Step 1, step 2, step 3, step 4. This is what it is in oncology. If that's the case, then actually oncology is not that complicated, right? Because I'm forced to do step 1, step 2, step 3, step 4. I have to do it. In fact, in my practice, if I deviate from the pathway, I have to justify why I deviated from the pathway, okay? So, for example, if you have pancreas cancer, right, which is what Patrick Swayze had pancreas cancer. My grandmother had pancreas adenocarcinoma. I think Alex Trebek now has pancreas cancer. And it's basically you get some kind of chemo. Maybe if you're lucky, maybe you can get surgery. Maybe you get some more chemo. Maybe another chemo. Maybe a clinical trial, and that's it. That's pretty much what happens. And you know, if you get 2 or 3 years out of it, it's actually pretty great. If you have lung cancer, and these are all getting better, don't get me wrong. I don't want to be too pessimistic. But maybe you can get surgery, which would be awesome. And then maybe some chemo, maybe some more chemo, maybe another clinical trial, and then hospice. Right? This is how lung cancer usually works. And colon cancer, which actually has gotten much better, usually you get some kind of surgery, you get some kind of chemo, and either you do great or you don't. Right? And so these are the pathways that we have to follow. And it's because the disease is the way it is. But neuroendocrine is not like that at all. So neuroendocrine is more like this. So you start with like some kind of treatment. Most of you had surgery before. Then you might get on some kind of hormone. And that works for a while. And you got some liver lesions. And maybe they'll do a little embolization for you. And maybe they'll give you some medicine. And maybe you'll have some more surgery, right? People have had multiple surgeries before. Oh, this is pretty bad. Maybe we'll give you a little bit of chemo. Maybe we'll give you some other therapy. Oh, you can't have more radiation. And we should give you some bland. And then it just kind of floats around like this. Does anyone feel like this? Anyone feel like this? Anyone go to a doctor's office and just like literally like see these words floating around? Right? And so that's kind of how neuroendocrine is, right? And that's what makes it so challenging. Because my job is to try to make all these things settle down for you, right? So because it's true. Every one of you might need every one of these therapies at some point in your lifetime, in your journey, right? But if I can do all these things and get you, no guarantees, but if I could get you to 85, would you be pretty happy? Yeah, you'd be pretty happy, right? Because by 85, well, who knows who'll be president when you're 85 years old, but if I can use all these things and get you to 85, then I think we've done our job, and anything beyond that is just gravy, right? Because everyone hears that word cancer, like, oh my gosh, that's it, you're done. 3 months, that's it, you're done. But if we can turn cancer into a chronic disease rather than an immediately deadly disease, then we've done a lot, okay? Like, I may not be able to cure you. I'm sorry, I can't cure you. Like, for example, I can't make Keith any more handsome, right? It's just cannot be done. Cannot be done. So I may not be able to cure you of your disease, but if I can get you to live with the disease, understand the disease, and keep on punkering along, then that would be terrific, right? I'll give you an example. Do you know what was the deadliest childhood disease in the 20s? Well, actually, in the teens, like 1910. It was juvenile diabetes. Yeah. It was like a deadly, deadly, deadly disease. Yeah, infectious diseases were terrible, don't get me wrong. I mean, it was a different time then. But the one disease that killed kids almost in a course of months was juvenile diabetes. So what we call type 1 diabetes now, because insulin didn't exist. So you would watch, you know what the treatment was for type 1 diabetes back then? Starving. You would watch your child not eat anything, turn into a skeleton, have this big fat belly, go into a coma, and die. That's what happened every single time. So when insulin was invented, I mean, it was literally that dramatic. There was a young boy, he was about 15 years old, he would have died in a few hours probably, so the story goes. So this very famous doctor injected this insulin into the kid, and the kid rose up. And they said it was like watching the dead rise. And so then the next person who got it, I mean, roughly, was the daughter of the Supreme Court Justice. And she survived. And now we know a lot of people with juvenile type 1 diabetes who are living, good, strong, healthy lives with their little pumps. So if we can turn it into a chronic disease, then it's manageable, okay? So that's, if we can reframe some of the thinking. It's not perfect. So for the next maybe like 20 minutes or so, I'd like to kind of go through some of these things and even get your opinion on it, but do a little bit of thinking. So How do I understand my disease and how much do I want to understand, okay? That's hard because you have to ask yourself really who you are, right? So if you're the kind of person who wants to take control of it because you don't trust somebody else, then by all means, I think it's important. There are a ton of resources out there. This is a great place, you know, to get the support. But you have to ask yourself, because there are some people who are just like, please, I just want to put my head in the sand, tell me what to do, and I'll live my life, and that's okay. And that's not wrong. It's not wrong, right? And so that's a really important kind of first branch point, deciding. And that's kind of depends on who you are. Again, for the people in this room, you want information. I know, that's why you're here, okay? But for the people who don't want to know, what I do is I say, no problem, please show up for your appointments, do your scans, let me just think about this. I'll talk to you, it's usually a man, unfortunately. I'll talk to your wife. No, it's true, it's true, it's true. I'll talk to your wife about it, we'll figure it out, and you go on doing what it is you want to do. And it kind of works out okay. It kind of works out okay. And then there are people in which we spend an hour, right? So for the people who have flown to Denver to come see me, you know, I sit with you for an hour. And we go over all of your questions because I want you to leave there empowered, understanding your disease, understanding your pathway, understanding what the options are, and so that when you're empowered, you feel like you have control over it, right? You framed it in such a way that I have control over this, and it's meaningful to me, and this is what I'm going to do, and good, I feel good about this. And that means you can go out and explain it to your family members, and they can understand that you're not dying in 3 months, so that inheritance that I thought Lance was going to send me, not happening. Not happening, let me tell you. I was hoping. But anyway, but I'd rather be here. So those kinds of things. So you can reframe it because it's a different kind of a disease, right? We think of breast cancer. Remember how breast cancer would kill women all the time? And it still does. I'm not saying it doesn't. But there are so many survivors of breast cancer now, which is great and wonderful. But breast cancer is a varied disease. There are very indolent versions of it. There are very aggressive versions. Neuroendocrine is even worse. They're like 85 different flavors of neuroendocrine. So one of the reasons, and we can talk about why this is so important, is because there are an extremely few number of people who can sniff out the 85 different flavors, okay? So this is a question that you have to just ask yourself and just decide what you want. I would always hope that this would be someone who wants to know about more of the disease because it's empowering. But some people do not. And we just have to accept that as a practitioner or as a caregiver sometimes, that that's how it is. And sometimes I think it's more challenging for the caregiver because they want their spouse or their mother or parent to know more and, you know, take control of it. And sometimes it's not the right thing. So we have to accept that. Okay, so now this is a tricky one, right? Because how much do I trust my own local medical team, right? So the classic example was like that emergency room case where you walk in, and, you go in for your vague abdominal pain, or you've had abdominal pain 4 or 5 times. Oh yeah, who's ever gone to the emergency room like 4 or 5 times with abdominal pain, right? And they just kick you out. Here's your morphine, here's your Toradol, get out, you're okay, right? That's a very common story too. And again, it's frustrating. It's frustrating. And so your relationship with the healthcare system becomes a little bit tenuous, right? I would argue that's probably true. And so then it becomes a problem because, well, who do you trust, right? This person is supposed to be they're doctors. Doctor means to teach, right? They're the teachers. So they're supposed to teach you about what it is and what to do. But if, you know, you're not always sure exactly what's being said is correct, then it leaves you with this very unsettling feeling, right? Because sure, that physician may have hundreds and hundreds and hundreds of patients to see, right? But you only have one life, and you only have one shot at taking the best care of your cancer, I would say, right? So you have to kind of decide this. And it doesn't mean that you don't trust them, but maybe it would be good to supplement the team. Maybe it's not that they just don't know. I don't blame them, right? You know what it's like to be a general medical oncologist? You got to know vaguely how to take care of like hundreds of different kinds of cancers, right? Thank goodness there are these pathways, as far as I'm concerned, because it's so complicated. They got to know bladder cancer, bone cancer, nose cancer, skin cancer, lung cancer, colon cancer, pancreas cancer, liver cancer. I mean, it's very, very complicated. So if you do that, if you're a general medical oncologist, it's tough. And then they want you to do neuroendocrine? I mean, it's a lot to ask for. It's a lot to ask for. So it's nothing that is personal or anything. It's just what they do for a living, right? That's tough. So once you kind of figure this out, then you've got to ask yourself, well, how much do I want to dictate my own care? I know for sure there are people in this room who basically walk into the office and tell the doctor like what bloods to draw, right? When they need their scan, and when they're headed to, you know, their specialists at Cedars-Sinai or Stanford or Denver or whatever, and then they come back with some report telling them what to do, right? Does that sound familiar to any of you? Yeah, it's super familiar, right? Because that's kind of how it is. Now, that's not a bad thing. That is not a bad thing. So if that's the kind of person you are, then by all means, you should do it because it's empowering, right? It gives you a sense of control over what's going on, which is great. But the reason it's actually a really good thing is because I communicate with other doctors through fax. Through fax, right. And you know, I don't even really know how to run a fax machine anymore. But apparently that's like the only like HIPAA compliant, like I can't email stuff because it's like HIPAA compliant apparently. I'm like, really? So I can't send them an email, but the Russians aren't going to read my faxes? Is that what they're saying? Let me tell you, the Russians are reading my faxes. So, but that's how I do it. And so if I don't send the right report, or if they don't send me the right report, or if I can't get the disc to them or whatever, I mean, has anyone ever tried to send a disc to my office? Yeah, you know what a pain in the butt it is to send a disc to my office? It's hard. So what do I tell you to do? Go to the radiology place, pick up the disc, put it in FedEx, and call me and make sure I receive it, right? I know it's the 21st century, except sometimes it doesn't feel like it. So this is actually an important thing because we're a team. Okay, so think of it that way. So if you have a net specialist, if you have a local physician or whatever, then you have, and you're kind of driving your own care, you're very much a part of it. I know it would be great for you to not have the disease. I got it. It does stink. And it would be great if you didn't have to think about all these things. I know. But if you have it, it's the cards you're dealt, and you got to deal with it as best you can. So be a part of it and be a part of the team. You don't have to decide anything, right? But as long as you can kind of work on these things and just to make sure you have a good team in place, then you can at least feel comfortable and confident that you can at least move forward. And you are just as much, you are essentially the captain of the team, right? I'm here, in theory, right, I would like to think, I'm here to serve you. I'm here to help you. I'm here to guide you for whatever it is, for whatever experience I have, to make your experience hopefully a little bit better, right? But that means that you have to be a part of it. But then you have to decide how much do you want to do that on your own. And that can be a real challenge as well, too. And that's where frequently caregivers come into play. Because sometimes the patient will come in, not really know what's going on, and the caregiver comes in with this big old book, right? How many of you have that notebook with like all the discs and all the reports and stuff like that? Yeah. I have mixed feelings, because when I see it, I'm like, oh no. Oh no. But at least I know that person I can have an educated, good, strong conversation with, so that there's value to be gained. Does that make sense? Does that make sense? So that's really important. But again, I think I'm preaching to the choir here, so it's not, maybe not. So now you have to ask yourself, do I need more support? Okay, and that's an important thing, because this is neuroendocrine is a little bit different. It is a chronic disease, right? Unfortunately, people who have pancreas cancer don't have a super whole lot of time in order to kind of, get involved with the community and do things like that. Breast cancer, there is a very strong community because there are survivors now. It's wonderful survivors. We don't have that many survivors from pancreas cancer. So, but we have a lot of people who are surviving with neuroendocrine cancer, so living with neuroendocrine cancer. And so do I need more support? Because it's true, people are not going to understand your bathroom habits, right? I do. But you can't see me every single day, and sometimes it's nice to just talk, and I don't know all the tricks, right? Some people, I have learned many, many things from the patients before. They said, hey, you should recommend this GNC product or whatever, so it's not that expensive. In, every conversation I have in Colorado is, well, what do you think of this, right? And so I say, look, I'm no expert, because I didn't live in the 60s, but a lot of people like it. So maybe there is some benefit to it. I don't know. I cannot say for sure. But that's a conversation that actually a lot of people have, like CBD oils and where to get stuff. And I'm no expert in this, but it is something that you guys can share. So that support is something that I will never ever really provide for you, but you guys can all provide for yourself. And so there are many opportunities that you can be a part of that. And of course, do I need more information? The answer should always be yes. Always be yes. Always be yes. Because the more information you have, the more you can be empowered. So I think those are kind of great places that you can get that information. And it may be dumb things. I mean, really, like I was just kind of breezing through Facebook, and someone was talking about after surgery, they got these like tape strips to help with the wound healing. I thought, oh, that's great. I mean, I don't do that regularly, but it's a good idea. Maybe I should, right? And maybe you guys can, explore those kinds of things and share your experiences and see how it goes, right? So those are very important things. Now, this is a good example of having information, right? So this is the project that LACNETS came up with. If you haven't seen this, it's called Net Vitals. It's like a 4 or some odd page form in that you can actually fill out, and essentially it's like a history and physical, well, like a history that you can give to the doctor, and then you have all this information. And I do want to say it came out of LACNETS, right? So what happened was last year, Lisa and Giovanna came to our Healing Net meeting. I'll tell you about the Healing Net in a second. But they went to this meeting, and we were talking about how important it was to have physician-patient communication. Every one of you in the room, I know for sure, has had some kind of struggle with some kind of physician-patient communication. So they said, we're gonna take this horse and we're gonna ride it. And so what they did was they developed this form, and I'm so proud of them because this is like a very useful product for people. So you can download it. It's a very important thing. So this is an example of how transferring information from your brain into my brain is very helpful if you have the right tools, okay? So kudos to the Los Angeles group for doing that. Yeah, really. Okay, so that's where the information comes. But now, would I feel better seeing a neuroendocrine specialist? So I have very strong feelings about this particular question because I am the neuroendocrine specialist. But I have very super strong feelings about it because I think that we can improve the care of people if you have just the right amount of information, right? So some of you have just come to see me, and we've had an hour-long conversation, and usually I think people feel better when they walk out the door, okay? For some of you, it was like 8 years ago, and I haven't heard from you since then, but I'm waiting for you to come back. But that means that conversation will hopefully be valuable for 8 years, okay? So neuroendocrine, I do believe to be a very weird, funky disease, right? It's like 85 different diseases. It's not just one, okay? It can come from your lung, it can come from your pancreas, it can come from your bowel, it can come from your rectum, it can come from your stomach, it can come from all these weird places, right? And then each one of those, there are like 3 or 4 or 5 different variants within each one of those organ systems, okay? And then each one of those tumors has like 3 or 4 branch points depending on pathology. And then each one of those has like 3 or 4 different branch points depending on where it spreads, okay? And how it affects you and what hormones it secretes, right? You see? Now there are like 85 different flavors. And it becomes very difficult to tease out all the 85 different flavors. I mean, for God's sake, Baskin-Robbins only had 31 flavors. And that was hard enough to deal with, right? So I think it's very, very important. Now, again, not all neuroendocrine specialists are the same either, right? So if you see a medical oncologist versus a gastroenterologist versus a endocrinologist versus a surgeon, you will get multiple different opinions. And I know that because when the patients come back, I say, how did it go seeing Dr. X and Dr. Y? They will tell me, like, yeah, I had a feeling they would tell you that kind of thing because we all come with our different biases. So it does go to show you that there are different kind of approaches to it depending on where you come from. So it's not easy. But then it like falls upon you again to figure out, what am I going to do, right? I just got 4 different opinions from 4 apparently neuroendocrine specialists. I still don't know what to do. And that's a challenge. That's a real challenge. So I do think there's value to it because then at least you get more information. You get hopefully all the information, and you can validate at least whatever it is you choose to do because that means there's some specialist who like supports whatever it is. Or minimally, you can hear all the different arguments so you can make a good judgment for what works best for you, right? For example, if you see a surgeon and the surgeon says, you have to have surgery tomorrow, right? And you have like 1 tumor in your liver and you feel perfect, right? And so you'll say, look, I'm okay. I think I'll sit for a while. Let me be. And there are some people who have 1 teeny tiny little tumor and they will say to me, Dr. Liu, I cannot sleep knowing that thing is inside there. Will you just cut it out for me? And I say, no problem, right? So it is possible I'm treating the psychological aspects of it. I got that. But cancer is such a personal experience that I can't judge. I will never know what it is to be you, right? And so all I can do is like serve you as best I can. And if that's an important thing to you, then I can do that. If I can do it safely, right? And I'm not gonna hurt you. Right? If I can do all those things, then I'm okay with it. So those are kind of the opinions. And then, unfortunately, sometimes there are physicians, and you may have had this experience, who don't play well with other doctors, right? And so, like I told you, like I feel like people like, I'm going to see another doctor. Good, go get another opinion. I think it's great. Just promise me you'll come back and tell me what he or she says. All right, I just want to know. And then there's some doctors like, oh, you don't need to go to Denver. He's just a surgeon. He didn't know anything, right? And maybe it's true. I don't know. But at the same time, if I can provide some other kind of, insight or opinion, that might be something that would be helpful. And unfortunately, sometimes the doctor just at home is like, I'm not going to take care of you because you went to go see his doctor. I actually have a very unfortunate one doctor who was like that. And the poor patient, she said that if you went to go see Lou, I'm not going to take care of you anymore, right? And so he did come down to see me, and I said, you're dying of gallstones. Did you know that? Yeah, he was dying of gallstones. So I took his gallbladder out, and then he got much, much better. So just to give you an example of a different kind of insight might help, and so it's always good to be able to work as a team. Luckily, it's a very rare kind of occurrence, but it does happen sometimes. And sometimes you get stuck in the middle, right? And I'm always like, whatever you want, whatever works for you, I'm happy to do for you. And that's my personal preference. But I hate for you to get stuck in the middle because it's such an uncomfortable place. It's like watching your parents fight, right? It's like not great. And sometimes you gotta say, look, I don't want to work with this doctor anymore. Let me just choose somebody else I can work with. And so that's something you have to decide sometimes. But that can be tricky. So it depends on how your team, how you put your team together, then you can decide how that works. Any questions about any of the things we talked about so far? I know these are kind of soft things. Any questions? Okay. Is that reasonable? Am I addressing these things? Okay, so then the next question kind of issue becomes, well, how am I communicating with my care team, right? So this is a very classic problem. So I usually sit with people for a long time. If you ever come to see me, I sit with you for a while. So I usually can extract a fair amount of information from you just by goofing around and talking to you about stuff. But a lot of doctors move very fast, right? They'll see you for maybe 5 to 8 minutes, maybe, right? And then there isn't that time to talk, right? So you don't get that information out. So this is actually more important for you, okay? Because you got to do this. You have the responsibility of telling the physician, well, she'll say, oh, how's your diarrhea? Oh, yeah, it's fine, right? That happens a lot. And then the spouse will be like, really? Did you really just say that? Because you're in the bathroom like 4 hours a day, right? And so, does that sound familiar to anybody? Right, sound familiar? And so then you have to have this conversation and talk about, and I know it's uncomfortable. Who wants to talk about poop, right? No one wants to talk about poop. I like talking about poop. I don't think my mom knows I specialize in poop, but I do. But it's super important. It's really, really important. And so that kind of communication, and there may be things that you don't even know about. So luckily, I have, I know what to ask about, right? Is your poop particularly smelly? Is your poop particularly oily? Is it particularly this and that? Do you go this many times? Does it wake you up at night, right? So when I ask you all those questions, because I do this for a living, right? And I'm not touting me, but I'm saying that I just do this for a living, so I know to ask these questions. But if you're having a conversation with a general, either GI doctor or an oncologist, he or she may not know to ask these questions. So why do I ask if your poop is greasy? I hate to use poop as an example, it's just an easier one. The reason I ask is a lot of people who are on the medication, their pancreas doesn't work and they can't digest fats. And I can fix that, okay? Why do I ask if it wakes you up at night? Because the number one complaint is always not poop, it's fatigue. It's always fatigue. And so then if I know that you're being woken up 3 or 4 times at nighttime because you're pooping, that's why you're so tired all day long, okay? So there are all these things that you have to kind of figure out. And so sometimes you have to be the one to tell the physician, yeah, I gotta tell you, my poop is really, really greasy and it floats. Well, that may trigger in his or her head, oh, hey, maybe this is actually a different thing. This is not related to the neuroendocrine. Maybe it's related to the treatment, or maybe I can treat this. So sometimes you can get away with this by giving that information, okay? And so when you give the right information, and then the next thing you think about, well, okay, is the treatment plan I just received reasonable, right? Because what if someone says, okay, you have this really low-grade tumor, but you have a lot of it, and so you should probably get chemo, right? So for those of you who are aware of our field, in general, it's not perfect, but in general, chemo doesn't work super well for most of our tumors, right? And so that may not be the right thing to do. And so I've had, there've been, I can tell you a countless number of stories, but basically, you know, if they're not quite familiar with how our disease functions, how it progresses, how it moves, what's responsive to, that's not usually the first line of therapy. And unfortunately, I've even had to tease out and figure out the pathology report, because the pathology report was done incorrectly. And so you got to figure that out, and then you can decide the right plan. So once you kind of communicate with your healthcare team, are you okay with the plan that came through? And if you feel comfortable with it, then great. Then that's how it should be, right? Unfortunately, sometimes the plans can be a little bit unsettling, okay? And that's just from like a personal level. Because sometimes, for example, if you see that there's a very famous doctor on the East Coast, and she tends to do less stuff. And then there are some doctors down in the South who tend to do more stuff. And so then you kind of have to figure out, well, am I okay with this doctor making me do nothing? Nothing, right? And it's not unreasonable. It really is not unreasonable at all. Because some of our neuroendocrine disease is so quiet and so indolent, you can do nothing for many, many, many years and keep the treatments in your back pocket and then just pull it out when you need it, okay? It's very reasonable. But not everyone's okay with that. Not everyone's okay that they can just like sit and do scans. Some people are great with it. They're like, oh, good. Leave it there, no problem, I'll just function and go on vacation. And that's reasonable, but you have to decide if you are okay with that, okay? And then there are some doctors who are like, yo, you need this and this and this right away, you need PRRT tomorrow. Well, maybe you do, right? And sometimes that is the right thing to do in the right situation, but then the question is, are you okay with that? And usually, I mean, I hate to say this, but usually the overly aggressive ones is with surgery, right? And so I'm a surgeon, and so I fall into this category. But are you okay with being like extremely aggressive about it? Well, some people are, right? Because they want to just get as much of that junk out of there and throw it away. Some people are because they feel terrible, right? Because they have tumors that are secreting a bunch of hormone and stuff like that, and they just want to get it all out. So those are the kind of questions you have to ask yourself, right? But you can only do this if you have this, right? If you have the right information and the good communication with your team, right? So this is actually super, super critical because unfortunately the plans can be from doing nothing to being super aggressive. And the answer usually is somewhere in the middle, somewhere in the middle. And so then you have to ask yourself, okay, well, do I understand all these options? Does this make sense to me? And am I comfortable with the whole care of the plan, right? And so if you don't understand why they're giving you chemo, you should understand why they're giving you chemo. Or if you don't understand why you're doing nothing about it, you should understand why you're doing nothing about it, right? So at least you can go home and say, I feel I'm at peace with this. Otherwise, you won't be able to sleep, right? And so, and then the other thing is, well, okay, so I have this stomach pain too. Could it be something else? Are there any other options? So at least you want to know what are those options, and we'll discuss some of them. But it's more complicated than that, right? I mean, a lot of people walk in the door, they have abdominal pain, right? I mean, I'm sure all of you have had some abdominal pain at some point, right? And so sometimes it's caused by scarring, sometimes it's caused by blockages, sometimes it's caused by the tumor, sometimes it's caused by the blood flow, sometimes it's caused by the gallbladder. I mean, there are all these things that can make it very complicated. And so you really have to understand what are all the options in order to kind of fix these things, right? And so we shouldn't neglect them. Sometimes I can't fix it. That is an unfortunate problem. But sometimes you can, and so you want to make sure you know what all those options are. And ultimately, does this make sense to me, right? Because it's complicated. I'm not going to say it's not complicated, but it's not rocket science, right? So it's got to at least make sense to you about why you're doing it, what's the purpose, and what are you trying to achieve. Because everything I do to you has risk, right? But however, if the benefit is worth it, then you're going to take the risk, right? Almost every one of you has had surgery, right? With your neuroendocrine. So if you've had surgery before, then you knew the risk of that surgery was worth it. And surgery is very safe now, so I don't want to harp on it. But that risk of that surgery was totally worth it because you were blocked, couldn't eat, vomiting, right? You can't live like that. That's life-threatening. So that's totally worth it. And so you want to make sure all that kind of makes sense to you, because that plan is what I can provide for you, right? And so I usually give this lecture to the junior doctors, and the one thing I always say is, the one thing you always want to think about is, have you figured out what's going on, right? Have you thought about neuroendocrine as a possibility? I know it's kind of off topic, but that's the thing. You have to be able to think about all these things, make sure you understand, make sure you have a good diagnosis of what's going on, because if you don't know what's going on, you can't fix it. You can't fix it. So that's super, super, super important. All right. So now it kind of gets to these questions too. Oh, sorry. So how am I going to balance my disease with living my life? Okay, and I think that's actually very important. That's a deep question because, I think about it all the time, right? I see people come into our office all the time and they're just ravaged by their disease, ravaged by their treatment. I don't know. Sometimes the treatment's worse than disease. I can't always tell. And it's hard, because I think to myself about my own mortality, what if I had pancreas cancer? Would I really want to go through all these things if it was bad? I don't know. But with neuroendocrine, because a lot of people can really live quite well, the one thing I always try to kind of preach is that if you can really improve your quality of life, you should always do that. Number one, quality of life, right? Because again, like I told you, you can get hit by a bus, right? You never know. And then, if you can fix the quality of life, then can I work on your quantity of life, right? So if you're living well, can I make sure you live as long, as well as possible, right? And it's in that order, quality of life, quantity of life. Because what if I told you you're going to live to be 103 years old? Wouldn't that be awesome? What if I told you you were in the toilet 8 hours a day, right? Then you'd be like, I'll trade my toilet time for, So, it's that kind of thing. But there are people who can go for quite a long time, and they can just feel miserable. And they come in, every couple months or so, and I see them, and I, try to help treat them and stuff like that. And they can still just feel kind of rough. It can be rough. So those are the kinds. So I always work on the quality of life. And I'll give you an example. So I have a patient I just saw on, Thursday when I had clinic. And he moved from Oklahoma to come live with us in Denver. And I didn't realize this, but he told me in 1 year, a couple of years ago, I did 7 operations in him. I didn't realize there was so many. And he's still bunking along, doing okay. And there's no question in my mind, 3 years ago, he would be in hospice, he wouldn't be here anymore. But because he wanted to be here, he wanted to fight through. He talked me into doing a couple of operations, actually. His daughter asked me, should I move up my wedding because my father will die? Right, so she asked me that. And I said, maybe, because I don't know. But luckily, we got him through. He was able to walk her down the aisle and stuff like that. He's able to live. Is it perfect? It's not perfect. It's nauseated, bowels all kind of locked up. It's not easy. But at least we're doing what he wants to do, which is great, right? So that's the thing. So the question is, how do I balance that with living my life? And that's really what I want you to do. And I've had this conversation with a whole bunch of you, right? Which is basically, look, you live your life, do what you want, make sure you're getting the most out of what it is to exist here on this world, and I can work on the rest. And it works out pretty well, right? This part is super painful, right? The healthcare part of it, the insurance part. So in addition to you guys, I have to do pre-authorizations, and I've got to call, and one insurance plan doesn't take this hospital, I can't figure it out. It is a catastrophic system, right? It barely functions, but I'm no expert in this either. But this is an important thing that you guys have to think about, okay? All right, so we've gone through a whole bunch of questions and things like that. Does anyone want to make any comments or any thoughts about anything that we covered? So her question was, if you have liver surgery and you dig them out, can it turn from a low grade to a high grade? So that's actually a very complicated question. I'll just answer it now. So what happens is, in general, that's not the case. Most of the time, they tend to be low grade. They all tend to be low grade. The problem is the disease tends to be what we call heterogeneous. So it's a little like each one of the tumors can be different, okay? So what you might have thought originally was like a low grade from your small intestine, for example, you can go into your liver and you can find it's more high grade, when in fact it's always been like that the whole time. So it's not that it changed, but it's always been like that. And sometimes even after surgery, because all the juices start flowing around in your body to heal, sometimes it can stimulate the growth of these little things too. I've seen that as well too. Not that it's disastrous, but it can happen. So it is possible, but not usually the situation. Right? Yes, ma'am.
Kind of along the same lines, same question. But if they didn't do your original biopsy, which is where they usually generate your grade level. If it wasn't in, per se, the liver, if it was in a different area that was low grade, but your larger burden of disease was in the other area. So is that what you're talking about being possible that it's...
For sure, yeah. So the question was like, if you biopsy one spot, and then, but really your disease is really, more troublesome someplace else, could that be the issue? And that's absolutely frequently the issue.
But it was labeled low grade because that's
Correct.
where they did the original biopsy.
Correct, yeah. So it may be labeled low grade because of where they did the original biopsy. And that's absolutely a pain in the derriere. It is. So what happens is, here's the classic thing. You will have a colonoscopy, right? Totally asymptomatic. You'll have a colonoscopy, routine colonoscopy. They'll go and they'll find this little thing, they'll biopsy it. And they'll biopsy it and you'll get some kind of grade or Ki-67 or whatever it is. And it's always low. The bowel primary is always, always low. And then they do a workup and they find a lesion in your liver. And they just label you as low grade. When in fact, that's actually not the situation. So if you took out a tumor, and I'll show you what a tumor looks like. If you took out a tumor and it's a ball like this, it's not uniform, okay? So you can have little hot spots of activity. So even depending on where you put the needle, you can get different results, okay? So there's a lot, so part of the reason why I always think it's so good to see a neuroendocrine specialist because I can also smell the problems that have happened. So very frequently what people do is they'll stick a tiny little needle and do what's called an FNA, an aspiration. I'm sure you all have had that. They just go through your mouth and go into your pancreas. And they take a tiny little sample and they do a Ki-67 on it, and they say it's low grade. Well, they did it on like on 15 cells, right? So that's really tough. It's not until you cut the whole thing out and cut it in half and look at it that you can really have a sense of what the activity is and what's going on. And ultimately, none of it is as good as the test of time. So when you, over the course of 6 months, 12 months, 3 years, then you can really know how aggressive or indolent your disease is. Recurrence, growth, yeah, scans, whatever it takes. Yeah, exactly. So all those things are very important. Yes, ma'am.
I've heard different things that neuroendocrine cancer isn't curable, and yet sometimes after surgery, if I've gotten a scan, they might say NED, but I still have carcinoid syndrome. And I go on to different sites, and some say it's not curable at all. So I just wanted to ask you today. It is so confusing.
Sure it is, yeah. Okay. The question you ask is very complicated. It sounds simple, and it's not. Okay, so here's the deal. There are multiple presentations. Like I told you, neuroendocrine is a whole variety spectrum of diseases, okay? There is a brand that comes up which in patients are heavily symptomatic, with an extremely small burden of disease, okay? And then people, and this may sound familiar, right? And so then people will go and they'll cut out that little neuroendocrine tumor in their small bowel, and then they'll say, you're cured, okay, right? And then you still feel terrible, right? You still have all these symptoms, all these things going on. So that is a scenario. So Dr. Odoricio, he's a very famous doctor from Iowa. He calls that carcinoid complex, he calls it. Because really what is, it's more of an endocrine problem rather than a malignant problem, okay? So that is a very common situation in which you had like one little birthmark that grew a little bit, not birthmark, but like a little mole, for example, that grew a little bit bigger than all the other little guys. But the other little guys are still there, and so you still have a lot of symptoms. So are you cured? Maybe, because I removed that growth out of you, that growth, but your disease, that endocrine process still cooks and still persists, right? And so that can be a problem. The reason we like to say that neuroendocrine is not curable, okay, and you can see I hem and haw when I say this, is because the recurrence rate of neuroendocrine malignancy is very high. So people will frequently say, for example, oh, it's slow growing. Sure, it is slow growing. But the fact of the matter is it spreads super fast. Most patients who, like, for example, who have small bowel or pancreas, they walk in the door already stage 4. It's spread to their liver, it's spread to their bones, and most of the time we didn't even know about it. When I first started doing gallium about 10 years ago, I was finding stuff that no one could see on the other scans. And I said, look, she's stage 4. She doesn't need an operation. And so it was completely enlightening to me because now I realize that it's a very aggressive disease because it just spits out all the time. So, but you have to understand the differences. So we always continue to check because I've also had patients who had like surgery when they're 18 years old. They were told they were cured, and now they're 45, and they have it in their bones, right? And so it's hard. It's really hard. And so this is why having someone sniff these things out for you, explaining it to you, and making sure, right? So I speak in generalities because I cannot speak to anyone individually. I can't speak to you individually. But I've seen in many cases patients who've had that little neuroendocrine tumor removed and they still are very symptomatic. And it's not because that tumor was causing all the problems, because there's all this other endocrine problem going on. Does that make sense? Yeah.
We have some questions from online that
Sure.
were submitted. One person writes that his wife had PRRT that ended in November and is still having so much fatigue, like sleeping 17 out of 24 hours. Is that common to go on so long? So he's about 6 months out from PRRT.
Yeah, again, that's impossible to say. I cannot say. Fatigue is like the most vague symptom there is, except it's also the most common symptom there is. Fatigue can be caused by anything at all. So the common thing that I can tell you is that in general, about a week after PRRT, and we can talk about the PRRT in a second, fatigue is very common, okay, in any of your situation. So for about a week, you'll be very tired. But you can be tired because you're running out of liver, right? So you could be out of liver failure. You could be fatigued because you're pooping all the time, and so you can't sleep. You can be fatigued for so many various reasons. You can be fatigued because of the medicines you're taking. It could be your high blood pressure medicine. I don't know. So I cannot tell you for sure. That is not normal. Sleeping 17 hours is not normal. So that should be something someone should think about.
Great. Okay, this is a little more answerable maybe. Are you a fan of surgery for stage 4 PNET metastatic to the liver?
Well, that's interesting. That's hard to say. So the answer is, in general, if I can do it safely and well and eradicate almost all the disease, I am a super fan. I'm also a fan if you can combine it with other therapies too. So, for example, if I'm going to debulk someone and get all that big stuff out, and maybe there's like one or two little schmutzy little things, and I can chase it with the PRRT and treat it with PRRT, I like to do that. Because what I found, and again, this is totally just experience, is that the big lesions aren't so awesome for the PRRT, whereas they're really super great for surgery. I can just go scoop them out and put them in the garbage can. Whereas the PRRT is a little bit incomplete in the way it treats these larger tumors. So you have to think about that. And I'll explain in a second, yeah. Go ahead, Gina.
So what is your opinion of whether or not to remove a slow-growing, small, as in 6 millimeters, size tumor in the lung? Is surgery always the best option if it has grown very slowly, approximately 2 millimeters in 5 years?
That's a very specific question, so it's hard for me to answer that in context. But in general, very, 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 very small lesions in the lung, we don't go after, because lung surgery is no small feat, okay? And if I had to go back into your chest, that's even harder than going back into your belly. So in general, totally in general, we tend not to do things like that, yeah.
If tumors are visible on a CT, why would they not show on a gallium scan?
That's actually a really good question. So that actually, are there any more questions?
There are a few more, but we can...
Well, let's stop there for a second. Okay, so that's actually a good question because it kind of gets into for example, we're talking about decision making, right? So here's a very classic question: do I need a gallium scan? Okay, that's the question that I hear, and this is the answer. Absolutely, all the time, every single time, right? Let me explain why. I have particularly strong feelings. If any of you feels like you want to have a seizure, let me know. I will advance the slide. Yeah, I'm about to have a seizure, so let me explain. It's fine. So that gets into the question from online, which is basically, what do I want to know? What is the information that comes from a dotatate gallium scan? So just for you, if you're not familiar with this is a molecule called gallium dotatate. And what it is a guided missile with a cage with a light bulb. That's what that is, okay? That's all it is. That's all it is. And what happens is, when you have this test, it tells me whether or not your tumors express something called a somatostatin receptor, right? It doesn't take pictures of neuroendocrine tumors. It takes pictures of a somatostatin receptor. The problem is, it's kind of like this. You can either have hair, or you can be bald, right? I'm looking at you gentlemen here. So if you have hair, and luckily 80% of our neuroendocrine tumors from the pancreas and the bowel have hair, then it will show the ones that have hair, okay? But there are some that are bald, And so you won't be able to see it on the dotatate scan because it doesn't have the receptor. So in the digestive tract, it tends to be a much higher percentage. But in the lung, it's actually 50-50. So a lot of people don't even respond to this. So when people, anyone who's seen me on Facebook, I'll say, please do all of your workup before you have surgery. You want to take all the pictures and examine things and figure it out before surgery. Because the moment you take that tumor out, I have no idea if it's bald or if it has hair. Does that make sense? Make sense? Yeah. So to answer the question online was, how can it show up on CT scan and be negative on gallium? Well, in fact, if you have a bald one, then it won't show, right? Or it could be something else, right? So there are some people, many patients I've taken care of, who like have breast cancer and neuroendocrine, right? So now I got to figure out, is it the breast cancer recurrence or is it the neuroendocrine that's recurred, right? And this is where gallium can help, because if it's gallium positive, and when I say gallium, I mean dotatate. If it's dotatate positive, so it has hair, then usually that helps us. Whereas in general, breast cancers are bald for this, and so you can kind of help figure that out. But that's the answer why.
So there's a related question, which is kind of the opposite. So if there's uptake on the gallium-68 scan in multiple areas of the spine, would it be possible that they are false positives if it does not show up on the conventional imaging like CT?
Unlikely. So what happens is, and it depends, right? So the reason why I can't do medicine over Facebook is for this reason, right? It's like it all depends. Like the details, the devil is truly in the details. So for example, if someone has a very, very high, strong uptake, like they have a ton of hair on their tumors, then you may not see it. It may be more sensitive on dotatate, right? Because if you get a CT scan, it misses stuff all the time. It is a wonderful and amazing test, don't get me wrong. But you have to use the right test for the right thing, right? So for example, if you had a flashlight, but you had to dig into your, I don't know, like into the walls, right? The flashlight may not be adequate, right? It's a good light source, but it may not be adequate to do the job you want. So maybe you need an MRI, maybe the gallium is the right test. So you need to have the right test. So to have them not show up is highly likely. It just depends on the situation, right? Maybe it shows up on a specific sequence protocol on MRI and not on CT because they just, it doesn't show up. So the answer is yes, it's very common.
This is a little more general. So does your treatment recommendation change depending on where the primary tumor is?
Oh, yeah, for sure, right? Like I just told you that there are 85 different flavors of neuroendocrine, right? So depending on where it comes from, the biology is completely different. Where it comes from in the bowel makes a difference. If it comes from right at the very, very end, it behaves a different way. If it comes from the very, very front, it behaves differently. If it spreads inside the mesentery a particular way, it behaves totally differently. If it spreads to the liver and like on the surface of the liver but not inside the liver, it behaves totally differently. So stomach, there are like 3 to 4 different versions in the stomach. In the lungs, I can sniff out like 5 different versions in the lung. Yeah. In the rectum, same thing. So it makes a huge difference. A huge difference. Yes, ma'am.
Should I be leery if my pathology report on my CCGA says there was an uptake, could be inflammation?
I don't know. It's a little too specific. I cannot tell you for sure. In general, if you want to have a second opinion, I always encourage that. I can't tell you for sure. Yeah, but it does. There can be false positives for sure. Yeah, and the problem is that the dotatate scan is relatively, like I've been doing it for a long time, but it's relatively new. So that means there are a bunch of doctors who have no idea what they're looking at. I mean, they're smart docs. They just have no experience, and there's no like training mechanism in order to teach them. Yes, ma'am.
Your new patient, you see a GI specialist, and they said, I might want to give you a scan. When do you give the patient a CT scan or a gallium scan?
So it all depends, right? Again, it's hard to know. Depends on where it is, depends on what organ I'm looking at, depends on what I'm trying to...
They suspect in the mid-gut.
Yeah, so that person always, for me, always gets a CT scan, an MRI, and a gallium scan.
3 of them.
Oh yeah, for workup,
But
yeah. Otherwise you'll never know.
But right now, insurance, this are very expensive tests. They
Yeah.
usually the
Yeah.
doctors has hesitated to give it to you.
Right, right. There is some truth to that. Except what I found is that if you don't have the right information, you can't adequately take care of the patient. So I will fight for that. I think they're a little bit more lenient with me because they know I do this for a living. And so we have all these like papers prepared and stuff like that, so we can usually get it through. But it's getting better. It's getting much better. So I would encourage it to be done. Yeah.
One question that comes up very often is for now that we have PRRT here is what is the follow-up in terms of imaging post-PRRT?
Oh, that's hard.
And do you do any imaging in the middle of the 4 cycles?
Yeah, yeah. So that's a hard question to answer. Basically, no one has settled on this. I stopped imaging in the middle. You know what? Let me keep going, and I'll answer. Keep saying that question. Yeah, let me answer her question. I'll keep going. So the question was basically, what happens if you have, like, I think, kind of inconsistent expression of gallium within your tumors? That's hard, because not any one therapy is going to hit all of it at one time. So I can't answer that specifically for you because I have to see it to know. But it does modify the way I think about the disease, yeah. So the reason here, just so you, a gallium scan versus an Octria scan, this was the test we used to use. I'm sure a lot of you had it before, but this was an example of a young man from Pennsylvania. He had this big tumor here, he had this big signal here in the middle. They couldn't figure out what it was. So he came to see me about 8 or 8 years ago, excuse me, and he got a gallium scan. He actually had this. Yeah. So I always encourage people always to get this test and never to get this test. Okay. So if you can get this, you don't have to, right? You don't have to be a nuclear medicine doctor to know this. Okay. Let's just talk about the therapies real fast because I want you to at least be exposed to them so you can think about what it is. So there are a bunch of different things and they do different things, right? So surgery, I'm a huge proponent of surgery because I think it works really, really well. It's a local regional therapy. You can give suppressive hormones, which many of you are taking, but that affects your whole body. It's systemic. You can get hormone synthesis blockade. There are these pills that can block the hormones, which is important for your symptoms. There are these molecularly targeted agents which can block certain like pathways it's a systemic therapy. You can have chemotherapy, which affects your whole body. You can have what's called liver embolization. Many of you had that before. It's a regional therapy that only affects your liver. And then you can have this PRRT, peptide receptor radionuclide therapy, which is also systemic. So there are actually quite a few tools in the toolbox. There's more than this, but this is kind of the foundation. So I think of NETs very, very differently, okay? You have to think about tumor control, okay, which is very important. You got to think about symptom control, right? Because quality of life, like I told you before, is a very high priority for me. And then you have to have hormone control, too. I think people forget this. When you're a medical oncologist, you don't think about the hormones that come out of this. This is an endocrine disease, right? So the silos of our field sometimes cross, but sometimes the doctors don't cross the fields, right? So it can be a challenge. And only then can you get real comprehensive disease control. The only problem is it's like this. It's a very, very, very slow process. And we're going to watch this young turtle cross, because I need a drink of water. But that's what it is. It's a very slow process. And so it's a marathon. So I've got to think about what am I going to do for you in 5 years, 7 years, 12 years, 15 years, hopefully, if we're successful. Okay? So the one important thing to do is you got to cut the thing out, because it is a mechanical disease. It is a mechanical disease. It is not good to have a softball in your belly or your lung where it doesn't belong, right? Does that make sense? Like when I put it that way, it's like so obvious, right? Anyone know what the second therapy should be? That's right. You should cut it out again. That's right. You should try to cut that thing out again if you can, because it's a good therapy, and usually they can recur. You can do it again. Anyone know what the third therapy is? Yeah, that's right. Good. All right. Good team. Good team. I like it. I'm exaggerating a little bit. But I just want to express to you that surgery is a very important thing. Why? I didn't make this up. There's a team from Minnesota, right? This is an old one, but look, it's a plea for resection, a plea in a professional journal to increase survival. And this group was very aggressive about debulking patients. This is the group from New Orleans, very experienced group, same thing. This is the group from Canada, and they all agree that you should try to get this stuff out as best you can. It's not perfect, right? But if this is colorectal cancer, and this is kind of old information, but this is colorectal cancer, if you can remove the colorectal cancer metastases, the patients do better. If you can do it in neuroendocrine, they're even better than colorectal cancer. So if you believe in this, and this is standard therapy, if you believe in this, then you should believe in this, right? The only problem is some of our oncology friends don't know this and therefore don't believe in it. So it's something that's very important to at least evaluate. It's not for everyone, but it's something to evaluate. They found that if you can remove the tumors, people feel better, right? That makes sense. You remove the source of your hormones, right? Very important. People have had improved performance status. I didn't think this until I started doing it. I had patients beg me to do this operation, and I did it, and they felt much better afterwards. I mean, I guess it's an amazing placebo effect, but usually it's just because you're throwing the garbage that's making all these tumors, these tumors into the garbage. You get them out of your body, people can feel better. Is it perfect? No. Do I cure you? Probably not. But if I can make you feel better, then that's an important thing to me, right? And so what we had to expect, so this is the whole cure thing that she had brought up. The disease comes back, and that's the problem. And so it's not perfect. None of it's perfect. But this is kind of what a tumor looks like if you've never seen it before. So I hope no one's grossed out. I'm going to show you a couple of gross pictures. So cover your eyes real quick if you don't like it. But this is a primary tumor of the intestine. It's very, very small. And then it can spread to the liver like that. And so here's an example of small tumors. This is why sometimes you take a biopsy of it, it's incorrect, because it looks so small and teeny tiny. It hasn't grown that much, right? Here's another one here. Here's another one here. It's not impressive. It's really not impressive. But then you see that little ball right there? And then you can see here's one from a pancreas. This patient was almost completely asymptomatic. Yeah, and she had this big ball coming out of her pancreas here. Here's one that comes out, it's hard to see, but it comes out of the lung right here. So there's one right in the lung. And then, so some people, when they present, their stomach hurts all the time. This is why. Just imagine if you're eating food and you're trying to get food through this knotted bowel. It's very difficult, yeah. And sometimes, if I can kind of get all these tumors out, I can really just like pluck them out and kind of get people cleaned out. It helps a lot. So that's what we call a complete response. Yeah, look, there are a lot of things here. So I'll just kind of zip through these. They're kind of gross, yeah. We'll zip through these things. But you get the idea. You get the idea. But there are a lot of really great medicines, right? So a lot of people take what's called a somatostatin analog, either lanreotide or octreotide. So that really works. They are quite amazing. They're really, really amazing medicines. And there are some pills that you can take too, some called sunitinib and everolimus. These work for pancreatic tumors. They help really quite a lot too. There's a medicine called temozolomide, which is a chemotherapeutic, oral chemotherapeutic drug that we can give that helps a lot too, with especially the pancreatic ones. We have this new medicine that helps to block the hormones. It's called telotrestat, also known as Zermello, and it helps to reduce the amount of serotonin that comes out of your tumors. And that can help a lot with symptoms. And if anyone's on it, you should, or anyone wants to get on it, you should know that there's a stand out there, so you can read a little bit about it. And also there's a really, really neat, robust nursing program too, where the nurse will talk to you about your symptoms and stuff and help to keep you on the medicine, tell you how to take the medicine. So that's all very, very important. There's all kinds of chemotherapies that have been tried before. Some work, some don't work. And then there's this interventional radiology where you can do an embolization and cut off the blood supply to the tumor. Some of you have had that before. And then here's the nuclear medicine. Here's the PRRT. I know you guys are doing a whole thing on PRRT, so I won't go crazy about it. But basically, for those of you who've never seen it before, remember the guided missile and the cage and the light bulb I showed you? Well, you can take the guided missile and put a bomb on the back of it, okay? So that's called PRRT. And basically what happens is that little guided missile comes along. It's the hormone. It has the bomb on the back of it, and it binds to the hair, the receptor on your tumors, and it goes inside, and you get radiation treatment from the inside out. And because it's a guided missile, it goes just to the tumors. So it's not like when you get radiation from the outside, it fries your skin and everything else that's along the way. It only treats the tumors. It's quite ingenious, yeah. And so here's an example of a patient who was in bad shape and got treated, and a lot of his tumors went away. And this is the information. So this is a little hard to read, but basically what happens is down is worse, up is better, okay? And if you got treated with just the standard treatment, they did worse. And if you got treated with the PRRT, they did better, right? You don't have to be a scientist to see this. You can drive a Mack truck through this graph, okay? And more importantly, same thing here. If you got treated, you lived longer, okay? So we're learning about those things. Here's an example of it. It's actually kind of cool. This is one of the very first patients we treated. You hear that? That's the radiation. Yeah, that's the radiation. And that's how we give it. We give it right through there. And then you can see, it's not like it's like, you know, Chernobyl in which like the radiation is traveling through the whole room. It's only once you get much, much closer to the patient that they become radioactive, that you can sense it. And it's not even that dangerous, honestly, like from a distance. Only when you get very, very, very close do you get that. Yeah, do you hear that? So that's what it is. And it's not even that bad. Like you can see the arrow doesn't even move up that much. But it's real, and it works. So really, the thing I want to tell you is that the art of neuroendocrine is not what to do, it's when to do it. It's when to do it. It's very, very important. Yeah. Thank you. Thank you. Thank you. Good woman. I'm taking her wherever she goes. Anyway, so you can see the guidelines are very complicated, and so they're hard to read. They're hard to figure out. So if you're a regular practicing oncologist, it's hard to tease out what to do for like the person in front of you. But because you can do this, or this, or this, or this, or this, or this. But what's best for you, sitting in front of me now, can be complicated to tease out. And so each individual really is very different. So, you know, zebra obviously is our mascot, as we can see. Yep, love it, love it. It's because every zebra is different, and, you know, it's such a specialized disease, and so each individual is very different. So I do want to say just one thing. LACNETS is an amazing organization, but we do work very closely with them. It's called the Healing Net Foundation. It's the foundation that we created out of Nashville, and really our goal was to kind of fill in the gaps. So education, awareness, you know, bringing people together, bringing doctors together. Here's a whole gaggle of us doctors talking together about new ways of thinking about neuroendocrine. But I just want to leave you with this video so you understand why we work so hard.
Earlier, we introduced you to two moms who are raising awareness about water safety after losing their children to drownings.
Now another mom is on a mission. She's turning her grief into something good. Megan shares this story and shows us how this mom is keeping a promise to her daughter, helping others one step at a time.
We took Anna to national parks when she was little, and we always believed in giving her experiences rather than things.
Gil Schenzel shared a love of the great outdoors with her only daughter, Anna Rose.
She grew up in the parks and out in the mountains. She loved adventure, and she loved running, and she was a great kid.
In 2016, when Anna was in college, she began experiencing numbness in her legs and unexplained heart problems. Body scans and MRIs could not detect the cause of her mysterious illness. Finally, a blood test revealed alarming results.
So we went to this endocrinologist, and she said, "I'm really sorry, but Anna has stage 4 cancer."
Those words shattered Gil's world. Anna was diagnosed with a rare, aggressive type of cancer, neuroendocrine tumors, also referred to as NET cancer. The cancer started in her adrenal glands, then spread to her lungs, spleen, and other organs. 20-year-old Anna endured several surgeries to remove tumors and grueling chemotherapy.
She was having a really bad day with chemo, and I just snuggled up beside her and I said, "Honey, I got this crazy idea. Let's go to all the national parks." And she said, "I'm gonna run them all with you, Mom." And she was so sick. And then we got, we got told it wasn't working after she'd gone through all of that. And it was really hard.
Anna died last year at the age of 21. Through her deep emotional pain, Gil is keeping her promise to run in 50 national parks, raising money for research and awareness about the disease that took her daughter's life. She calls this cancer a horse of a different color, so she runs as a zebra warrior. Gil brings Anna's teddy bear to keep her spirit close.
I want to do this whole trail someday.
At Cuyahoga National Park in Ohio, Gil was joined by others. Some are NET cancer patients who met through the support group and foundation, the Healing Net.
Cancer teaches us a lot about ourselves, doesn't it?
Yep, sure does.
I just want so much to let people know about this cancer. I just ask God every day to take my brokenness and use it to help somebody else. And if we can help save some lives, then I'm really good with that.
You are an incredible woman. Gil is 2 parks away from reaching her goal of running 50 national parks, and she's running another one tomorrow before her big finale Saturday at Rocky Mountain National Park. It's the same place her husband used to bring their daughter, Anna, while she was a little girl.
There's nothing like a mama's love.
Ah.
Nothing like it.
These mothers are incredible.
We'll be back.
Right, it is amazing. And Gil is a very dear friend, and she like brings me cookies because she knows I'm like overworked all the time. But she really is amazing. But this is why I work so hard, is because, you know, stories like this for you guys to make you feel better, and, you know, hopefully, you know, groups like LACNETS support them, because there are a lot of people that we can help. So that's it. That's all I have for you. Yeah, if I can answer like one or two questions, I got to go catch my airplane. But go ahead, Sonny.
I have a question about, it just seems like there's not as much research in the lung primary.
That's correct.
Why is that?
Because unfortunately, the lung neuroendocrine tumors fall generally under the realm of the pulmonary oncologist, and they're dealing with like worse cancers, and so they don't. It's not a high priority. Yeah, unfortunately, it's not. Yeah. Yeah. Well, neuroendocrine is generally not a high research. Yeah.
I just like when it metastasizes from lungs is fine. Those patients aren't right now. They're not eligible for PRRT.
Well, they may or may not be. Depends.
Yeah, one quick question. Do you do surgery first before the patient later on to
PRRT. Yeah, generally. Yes, ma'am.
Is there a liver-directed PRRT? Liver-directed?
There is. I'm not sure if it makes a huge difference, but some people do it. Yeah. Okay, gang. Thank you very much.
Thank you, Dr. Liu.
I hope that was helpful.
Thank you.